welcome again to this online HTA course. This is video 9 that provides an example of an economic evaluation. For this brief illustration of an example of a cost-effectiveness analysis, we use the following article, entitled A Cost-Effectiveness Model of Genetic Testing and Periodical Clinical Screening for the Evaluation of Families with Dilated Cardiomyopathy, an article that has been published in 2019. Thus, with our economic evaluation, in this example, we compare those two interventions, the cascade genetic testing versus periodical clinical surveillance, and we will look at both cost and the effect and at the relationship between the healthcare costs in this example and the quality of the two interventions. The research question of this example, of this paper, was to assess the cost effectiveness of cascade genetic testing in asymptomatic relatives of patients with dilated cardiomyopathy compared with periodical clinical surveillance. The study was conducted in Australia, and the author used the healthcare system perspective, then thus only included the cost from the healthcare system. And the willingness to pay, the threshold used by the author, was based on the Australian guideline and was in the range of $40,000 to $70,000 per quality, meaning that an intervention is cost effective if the ICER is below this threshold. The author used a model-based economic evaluation, and they combined a decision tree with a Markov model. Regarding data input, they included the cost of genetic testing, also the cost of screening, and the cost of different clinical events with the disease history of the patient. Medication costs were also included, and all of the costs were adjusted to the year 2018 in Australian dollar. For the outcome, quality adjusted was used as a preferred outcome and were derived from the SF36 questionnaire. The time horizon used in the model was lifetime, meaning that all costs and the effect were calculated over the long term of the patient, and a discounting was used, a discount of 5% as recommended by the guideline for economic evaluation in the country. The author used then a decision tree followed by a Markov model. Thus, as explained in another lecture, in a decision tree, we have first a decision node comparing the two interventions, the cascade genetic screening plus the periodical clinical surveillance, and the other intervention, the comparator treatment, is the cascade periodical clinical surveillance. And thus, there were then different probabilities that explain the pathway that different patients could have. If, by example, there is the proband genetic testing positive, it could be positive or negative, and leading to the accept of the cascade screening or the decline. And it is assumed that patients that are willing to get the genetic test and that have a gen positive will accept the clinical surveillance. And then at the end, there were different possible pathways in this decision tree. And in each pathway, there will be a Markov model that was building up by the author. And the aim of the Markov model is to really simulate the cost and the outcome of the different patients based on the evolution of the disease. And patients that accept clinical surveillance will not have the same evolution that patients that decline clinical surveillance. Thus, a few additional words on the Markov model. Thus, at every pathways mentioned here at the end of each decision tree option, we have a Markov model that the patient could move between different health states. And there are 5 health states being clinically unaffected: mild dilated cardiomyopathy, dilated cardiomyopathy, implantable cardioverter defibrillator therapy, and the death. And thus the patient can move between these health states based on different probabilities. And the probability could differ according to the pathways mentioned in the decision tree. And thus, in each of these health states, there are different costs and different utilities based on where we are. For example, if you are located in this implantable cardioverter defibrillator, the cost will of course be higher than if you are just clinically unaffected. And the utilities are also lower if you are in a state with dilated cardiomyopathy compared to clinically unaffected. And thus the author estimated the cost and the utilities and the probability to switch between the different states based on literature. Based on the model and all of the data that were calculated and searched by the author, they build up the model and then they get an estimation of the total cost and the total quality of the intervention. That you could see total cost, total quality for the genetic testing and for the periodical clinical surveillance. Based on this data, they apply the formula of the incremental cost effectiveness ratio, incremental cost utility ratio in this case, since they use quality, then the difference in cost between both interventions divided by the difference in the outcome and leading to an incremental cost utility ratio of 6,100 Australian dollars per quality gain. Since this I curve is below the threshold used to define an intervention as cost-effective, the intervention is considered as cost-effective. The author then conducted some sensitivity analysis to characterize parameter uncertainty. And a lot of analyses were conducted by the author. And they were presented in the form of a tornado diagram where we see the base case estimation, the 6,100, and we could see the effect of changing different parameters on the incremental cost utility ratio. And what we observe is that the model, the estimation could be sensitive to some of the parameters, especially these are the top of the tornado diagram, but overall it remains robust because we are always at an incremental cost utility ratio below $15,000 per quality gain, far below the threshold used in Australia to consider an intervention as cost effective. And we observe that the parameter that impact the most the ICER were the number of relatives that benefit from the program genetic test. We also see that the cost of the DCM medication or the cost of the sequencing were also affecting a bit the incremental cost utility ratio. This type of analysis, of sensitivity analysis, is also nice to have a better understanding of the parameter that really influence the incremental cost utility ratio. And in that case, they really confirm the potential cost effectiveness of the intervention as it's all of the analyses who are still below the incremental cost utility ratio. Then the author also conducted a probabilistic sensitivity analysis that was explained in another lecture. In this probabilistic sensitivity analysis, we estimate the probability to be cost-effective for different willingness to pay threshold. And we observe that the genetic testing has a high probability to be cost-effective. For example, if we use the threshold of €50,000, we have about 90% of chance to be cost-effective, meaning that at this threshold, there were 90% of the simulation where genetic testing was the most cost-effective intervention. And on average, where we are above 50% of both, we are near to our estimation of 6,000, what we also get in the deterministic approach. There's also a nice way to present and to characterize the uncertainty. And we really see that genetic testing has a high probability to be cost-effective at the current cost-effectiveness threshold in Australia. To summarize, using cascade genetic testing in asymptomatic relatives of patients with DCM is very likely to be cost-effective based on this paper. The author also concluded that the cost-effectiveness of cascade testing could even increase as the DCM pathogenic variant detection rate rise and new evidence for personalized treatment of at-risk individuals become available. Then we could expect even better cost-effectiveness in the future. Overall, this example, this economic evaluation is of good quality. However, do not forget that a model is only a representation of the reality and that there could have some assumption in the model. And validation of a model is just something really important. Most of the inputs that the author used were derived from different literature sources and some assumptions were made by the author. A potential limitation of this work is that societal costs were not included. The question of the transferability of these findings to another country like Netherlands is a bit difficult. There are some potential differences in the epidemiology, in the cost, potentially in the utilities between countries, which make the transferability of this economic evaluation a bit uncertain to other contexts. Ideally, we should conduct local, national economic evaluation to really see if an intervention is cost-effective in the country of interest. The reference of this paper and some additional useful references that you could also find in the course manual. Thank you for your attention.